Yeah.
Good evening, everyone. I, Dr. Madhavi Godbole, Treasurer, Society of Anesthesiologists, Pune, warmly welcome you all to today's webinar, Decoding Quality in Anesthesia Practice. This webinar has been organized by Society of Anesthesiologists, Pune and Society of Anesthesiologists, Maharashtra State. It's my privilege to introduce the moderator of today's session, Dr. Shalini Sardesai, ma'am. She was the former Dean at Srimati Kashibai Navle Medical College, Pune, and former Vice President, Society of Anesthesiologists, Pune. Currently, she is working as Professor in Department of Anesthesiology, Srimati Kashibai Navle Medical College, Pune. Over to you, ma'am. Thank you.
Yeah. Good evening, everyone, and welcome to this very interesting webinar on decoding quality in anesthesia practice, organized by Society of Anesthesiologists Pune in association with Society of Anesthesiologists Maharashtra State Chapter. At the outset, I would like to, this is a very great honor to welcome our President SAMS, though he is not there, but I welcome all SAMS office bearer, Dr. Avinash Bhosle, President of SAMS, Dr. Vikas Karne, Vice President, Dr. Sheetal Dalal, Honorable Secretary, Dr. Rajesh Tagadpalle, President-elect, Dr. Sachin Chandolkar, Treasurer, Dr. Shilpa Tivaskar, Editor of the SAMS newsletter, to this webinar. I also extend a warm welcome to all senior, junior anesthesiologists, my colleagues from Pune as well as across the Maharashtra for joining this webinar. We all know that perioperative mortality and morbidity is very high, almost 0.4 to 4%. Out of that, 50% mortality is preventable, particularly death after complications, that is failure to rescue. Regarding anesthesia practice, anesthesia specific mortality, the statistic is showing very less incidence, and that is mainly because of underreporting of the incidences or cases. Healthcare quality is central to modern medical practice and is defined as the extent to which health services improve patient outcome while aligning with current professional knowledge. Anesthesia practice represents one of the most critical and high-risk areas in healthcare, involving rapid decision-making, potent medications, and continuous monitoring of vital functions. Quality in anesthesia spans the entire perioperative period, from preoperative assessment to intraoperative care. If we set different protocols, observe various checklists, and reassess our own skills with adequate knowledge, will definitely reduce in perioperative mortality as well as morbidity. This webinar aims to explore the principles of healthcare quality in anesthesia practice, highlighting key domains, safety strategies, and quality improvement approaches that contribute to better patient outcome and safer perioperative care. So, welcome everyone for this webinar. Now, without any delay, actually today we are highly privileged to have national, international, eminent speakers, quality head at different institutes, and also NABH inspectors are here to enlighten us on different aspects of quality care in anesthesia practice. So without any delay, I would like to invite our first speaker, Dr. Shilpa Acharya. She is Professor Anesthesia as well as PG Guide, Head Quality and Accreditation Coordinator, Chairperson Clinical Governance, BVMFS Bharati Hospital and Research Center, Pune. She is a national speaker on healthcare quality and patient safety. She has done MBBS, DNB anesthesia, as well as MBA in hospital and health system management from BITS Pilani. She has got second prize in NABH slogan. So, welcome, Dr. Shilpa Acharya. Yeah, over to you, ma'am.
Yeah, so good evening. Thank you so much, madam, for the introduction. And, I first want to thank SAMS and SAP's all office bearers and all my colleagues and friends for this wonderful opportunity, to reach for this wonderful topic, at the state level. So the topic that I'm discussing today is the deciphering the domains of quality in anesthesia care. So let's start, what is the purpose of today's discussion? As Madam rightly said, that healthcare quality is the central, at today's modern era of medicine. And therefore, each and every care or every intervention that we are offering to our patients, there should be healthcare quality discussion that should be occurring. Now, this WHO data, that has been given by WHO last year, it states that almost 15% of the patient overall deaths are attributed to poor quality care in lower middle income countries, and almost 40% patients, they don't trust their healthcare systems. And it is very much obvious that the patient trust goes hand in hand with the quality care that you are offering to your patients. And inadequate quality or poor quality, it adds a lot of costs to the healthcare organization as well as to the patient. So always remember that the poor quality adds to the cost, not the, it is not that the good quality comes with the cost. And therefore, the out-of-pocket expenditure of the patient, if we consider, increases, if there is a poor quality. And the condition is also not, very better in the high income countries, where 10% of the patients, data says that they're harmed while receiving hospital care, and almost 7% there is hospital acquired infection. And many of the deaths that are occurring in the hospitals could have been prevented if the good quality care was offered to them. So, if we consider what is this healthcare quality, it should not just appear like a distant dream to us. We should be able to define what healthcare quality is all about. And therefore, we will be discussing the quality domains today. Now, as Madam has already given that the definition of the quality, it is the degree to which the health services for individuals and population increase the likelihood of desired healthcare outcomes, if they are consistent with the current professional knowledge. Now, both these terms that are used in the definitions are, important. That what are the desired healthcare outcomes that you are expecting, and what is the current professional knowledge. And we will see, in the next slides, that how we can impart this quality care to our patients. Now, it is needless to say that this definition or this quality care, it is, applicable for different care perspectives. It could be preventive and promotive aspects of the healthcare. It could be treatment, rehab, as well as the palliative care. And, by applying quality domains, we will be able to measure and continuously improve. And, it is also always happens that, who is responsible if something goes wrong? It is the quality or the quality professional. So, everybody of us, it becomes a quality champion or quality professional, the overall, the care that we are imparting to the patient will improve. So why quality matters in anesthesia? As Madam already introduced, that it is the most volatile branches, one of the most volatile branches of medicine. It is time critical. There are, system dependent factors. There are equipment that we depend on. There is team communication with the surgeons, with the nurses, with the patient relatives. It is very important. And one quality failure, it is a life and death situation. Like there is hypoxia, there is death, there is collapse. So we as a anesthesia professionals, we are quality champions, and the quality, we should always be a quality and safety leaders. For starting how we can implement the domains in anesthesia care, we should be looking back, at the history where, once upon a time where the surgery was a sickening sight. This excerpt from the New York Herald in 1841, surgery was one of the sickening sight. It was always taken as a last resort. Nobody would opt otherwise for surgery when anesthesia was not there. And then came, our Dr. Wells, who introduced, anesthesia nitrous demonstration, but he failed. Later on, where Morton, took over and established anesthesia branch per se. Right. And then the era of chloroform, which was popularized later by, by giving anesthesia for Queen Victoria by Dr. John Snow. Then came the era where Dr. Bayer introduced, a spinal anesthesia, where cocaine was used, and the evolution of anesthesia in the last century, so to say, from ETT being introduced, from the era where IV induction started happening when the barbiturates were founded, and the era after 1950, when halothane and then more and more different agents were being introduced, where we started continuous ECG monitoring, non-invasive blood pressure, an anesthesia patient safety foundation started in 85, and now till 2026, that we have definitely come a long way. Why, I wanted you all to just have a glimpse of history, because in the today's era, from the picture 1 to picture 2, where we are using a modular state of the art, operation theaters with anesthesia workstations, the important most factor that an anesthetist is considering is nothing but the patient safety. And therefore, this brings us to the first domain of quality, that is the safety. Now, Institute of Medicine has given us the 6 domains of quality, and the patient safety is the first and foremost domains. Whatever intervention that you are offering to your patients may not be effective, but it should not harm your patients, and that is the foremost requirement of the quality domains. So let us delve into the domains one by one. What are these domains? These will definitely help you, make quality a measurable thing, an actionable thing, and clinically relevant also. Now, few other domains apart from these 6 have also been given by US quality projects, like sustainability and eco-friendly care. Because in the today's era where green building projects, green hospitals, and OT we are considering, many hospitals are going for green OT certifications. The sustainability component can additionally be considered, and an integrated care and multidisciplinary care can be also considered. So let us start from the first component of safety, and it is defined by minimizing the harm that is we are catering to our patient or giving to our patients by virtue of them being admitted to the hospital, and we should be offering zero preventable harm to our patients. Now let us define what is hazard and what is the risk. Hazard, it is the source of the danger, and risk, it is the probability that the danger occurs. I'll give you an example. Like, suppose there are sharks in the water is a hazard, and swimming in that particular water is the risk that we are taking. And how we can implement that key, the safety component, that we all are trained, all colleagues here who are listening, all are trained by pre-anesthesia assessment and optimization, by imparting and implementing WHO surgical safety checklists for every patient. It might be a smallest of the small surgery. Now, we can correlate, implementing surgical safety checklist by, suppose there is an orchestra that is being played, doing a surgery is like playing an orchestra, and if there is no symphony between the different stakeholders, then the surgery will not be uneventful. And therefore, verbalization of the surgical safety checklist is important. For document purpose, you may have different signs on all the components, sign in, time out, and sign out, but actual verbalization, is it occurring or not? For different surgery, what are the risks that you are going to encounter? Have you defined it? Have you anticipated those risks? Have you taken into consideration those risks while you are verbalizing the checklist? Are important. Now here I want to quote the book by Dr. Govande, Checklist Manifesto. That gives us the story how that surgical safety checklist was formulated in 2007, and it almost took almost 2 years to formulate that checklist. So this verbalization component must be taken into consideration. Equipment checks like machine, oxygen monitor, we are regularly and routinely trained, and it has to be done. Drug safety, like labeling, because there are many near misses or many mishaps are likely to occur when you are injecting drugs. For example, verbalization of giving scoline, which is a high-risk drug, or verbalization of any high-risk drug before injecting. Like, I am giving scoline, injection scoline, so that everybody in the OT is alerted that now scoline is being given. So that labeling and verbal order, uh, saying loudly so that everybody is alerted and is vigilant. So again, that vigilance should come during induction, maintenance, and emergence. So this brings us to the international patient safety goal. Now, these 6 goals have been given internationally, and each of these goals is important for anesthesiologists. The first goal is correct identification of the patient by UHID and full name of the patient. Goal 2 is improve effective communication. This communication could be with the patient, could be with your colleagues, could be with the surgical team, could be with the physician from whom you are taking fitness from. The goal 3 is improve the drug safety, because all the medications in anesthesia are high-risk medications. So improve the high-risk medication safety. Goal 4 is ensure correct sites. So verbalization of the checklist. Goal 5 is reduce the risk of healthcare associated infection, and goal 6 is reduction of the patient fall. And for each of this patient safety goal, we can have some indicators and some measures that we will be seeing in the next sessions by other speakers. So every patient goal respect to anesthesia, we can monitor by different indicators also. Now, one of the important thing in the patient safety that we can, there is some gap or we can improvise upon is how we are risk stratifying our patient. Now, by traditional means, we are doing ASAPS classification that we are routinely taking, but it is a unidimensional risk stratification by ASAPS. So probably we can add more into that. Now, look at this example that I have given you. On the left-hand side, there is surgical risk score. The different surgery have been divided into 5 risk and categories, and the patient safety can again be categorized into 5. So for example, if a patient is posted for gynec surgery and patient doesn't have a comorbidity, so if we apply matrix by 5 matrix, the patient safety risk that can be considered can be 3:1, that is 3. So in the 3 category, the risk comes as low risk. But the same patient who is morbidly obese, the risk will be much high and it will come to high or very high risk category. So such risk stratification, we should, there is a little scope for improvement by adequate risk stratification that we are doing. Other risk tools that are available, that they are there, like surgical outcome risk tool and pulmonary complication anticipation. So these risk tool, like there is a modified surgical Apgar score that we can implement in our day-to-day patients. So this part we can definitely, there is a scope for improvement. The second component of the quality or the quality domain is the effectiveness. Now, there is a difference between efficacy and effectiveness. So efficacy is the capacity or the ability of intervention to generate a result. And if that intervention has got some meaningful effect on the patient, is the effectiveness component. Now, this effectiveness can be brought by different steps. We will see it one by one. So the first is the selection of intervention. So if you have a credentialed person who is doing that particular procedure or giving that particular intervention, then the effectiveness will be good. If that person is privileged, first should be the credentialing and second should be the privileging. Now, this privileging can be assigned to the faculty. It can be assigned to, different resident level. So that privileging should be done for all anesthesia personnel. Then, which medication you have, the system support, the medication, if they're available, the disposables and the equipment support is there or not. Then the accurate implementation and appropriate implementation of that procedure. And last is the vigilance. Now, this component of the effectiveness can be brought by evidence-based anesthesia care, that is providing care based on the best of the evidences, and it can be adopted for different pre-operative, intraoperative, and post-operative protocols. Let us a few words about the standard treatment guidelines, that these are the guidelines that are given by society or international or national benchmarking. And these can be always, utilized in our day-to-day practice. Even in the court of law, they will help you if you are sticking to a particular guidelines. And these guidelines, are we implementing the correct guidelines in our daily practice, can be, judged by different clinical audits and formulating different clinical care pathways. Now, look at this example that we have done at our institute, is formulation of this NORA pathway. Now, this particular pathway, there were few incidences at our institute, which started, we thought about it, that the NORA pathway should be created so that a standardized care can be given to our patients. Now, this particular pathway, we have defined which are different NORA sites where we are giving anesthesia. What is the pre-anesthesia, anesthesia, and post-anesthesia care? There is risk stratification by 2x2 matrix that we have given here, and which are different component, like if the case is for emergency, cases for elective, how differently we are going to manage it. And if we implement it, we will be able to give a standardized care which will be effective. Then let us discuss about the third component of the domain of quality is the timeliness component. And as rightly said that, no better person than anesthetist can, tell you what is the timely care, like, conducting or taking important decision in case of emergency. If there is a difficult airway, there is a CVCO situation, how the anesthetist, how we judge, everybody must have experienced that. So that timeliness component is very important, and it can be imparted by different stages of anesthesia, like avoiding delays in the pre-anesthesia care. OT start delays can be avoided. Emergency case response time can be calculated. If there is a delay in the post-operative, there is a breakthrough pain, how fast we are, giving our top-ups or giving any breakthrough anesthesia. So that can be monitored by timeliness component. The fourth component is the patient-centered care. It is defined by respecting the patient preferences. And these patient preferences they are just not, related to the anesthesia care, but it could be their cultural preferences, it could be their regional or spiritual preferences, their values and beliefs should be taken into consideration. So this can be imparted by shared decision making. Now there can be projects that can be taken. So there, if you search the shared decision making by anesthesiologists, you will get a tool, a checklist that you can definitely map or do a small study or do a small audit at your institute, that how far shared decision making, how is the patient's perception that anesthetist helped them to understand various options of anesthesia, and how where they helped the patients to choose one of the options. Okay, so this shared decision making is important. Clear preoperative counseling, anxiety reduction strategies. You cannot have a same approach for every patient. You have to give different care to different patient as per their needs. Then post-operative comfort and dignity. And there are different tools that you can consider, like patient-reported experience measure. So we have PREM and PROM that can be. So patient-reported experience measure and patient-reported outcome measures can be considered. So these small studies can also be undertaken. Now, for example, this EndoPrem tools. Now, patients coming for colonoscopy, you can utilize this EndoPrem tool, and whether the sedation was given and how is the patient experience when patients were sedated for colonoscopy. So this is an example how you can impart a patient-centered care. The next component or the next domain of quality is the efficiency. Now, just look at the diagram, given here. If there is effectiveness and efficiency. So if you plot the effectiveness versus efficiency, so the efficiency and effectiveness should go hand in hand. If you have effectiveness, but there is no efficiency, then there are some lost opportunities. And if there is efficiency, but no effectiveness, there is waste efforts. So both efficiency and effectiveness together will give you good results and good quality care. So this efficiency can be imparted by various mapping of OT utilization. If there is drug wastage, and by far always train that smallest of the, if there is a fentanyl which is remaining, we always have that we should not go waste. So even if 25 mics is remaining, we see to it that it is kept properly in the sterile environment and used for some other patients. So we by traditionally we are trained to reduce that, but again there are many other aspects of anesthesia care where efficiency can be monitored. So avoid cancellation. So by different indicators that we are mapping, there is some sometimes there is patient that are rescheduled, beyond 4 hours or beyond 6 hours. So avoiding cancellation, avoid rescheduling. Length of stay. What is the time that you are requiring for induction? What is the time that is requiring for reversal? So these metrics can be used. Now, this brings us to different types of waste, because by efficiency, we are reducing types of waste in the healthcare. So by, if you read it, the waste in the healthcare can be defined that there are 8 categories of waste in healthcare. So there are waste of defects, overproduction, waste of waiting, waste of non-utilized talent, waste of inventory, overprocessing. There is waste in the motion or transportation. So all these waste can be minimized, and that brings us to a concept of lean hospitals in healthcare. So these hospitals, there are some care hospitals or lean hospitals which have minimized waste. So, a project in anesthesia for lean care can also be undertaken. The next and the sixth component is the equity. Now, this component overlaps with the patient-centered care, that the quality should not be same for all. And as the picture says, that it has to be given as per the requirement. So elderly and frail patients, you give different care, pediatric and obstetric population. So, you should be treating vulnerable patients as the care which is required. You should prioritize the patient. For example, like we are taking, diabetes patients first on the list. So by doing that, we are imparting equity component of the quality domain to our patients. Then triaging, if you are having emergency, which patient can be taken first, right? Then case-based or tailor-made approach for every patient is again equity component, and emergency hour decision-making. So suppose there are 2-3 cases waiting, which case should be taken first? So this is by determining this, you are giving equity approach in the healthcare quality. So, anesthetist role as a quality leader, we are natural champions in the patient safety. We are champions in the checklist. We are champions in the simulation training, which is also coming in a big way. And we are always, there are key contributors or different hospital committees. So we will just sum up what with clinical case example, right? So this is a patient, 78-year-old male, 62 kg. A patient is diagnosed with left intertrochanteric fracture femur after fall at home at 2 p.m. He is ischemic heart, DES placed 8 months ago, is hypertensive and diabetic. He is on dual antiplatelet therapy, antihypertensive, atorvastatin and metformin. His preoperative status, he has to be taken emergency. Orthopedics is, telling that he has to be taken immediately. The vitals are stable. There are no fresh changes on the ECG, and echo is borderline ejection fraction. The labs, HB is 10.2, otherwise normal, and last dose of clopidogrel was taken in the morning. Now, if we want to implement all 6 domains of quality in the patient's plan, an anesthesia plan, let us just see how we can do it. So this possible anesthesia plan can be, there can be a multidisciplinary discussion with cardiology, orthopedic, and anesthesia team, which can be documented in your IPD case sheet or in your PAC. You have to continue aspirin. Again, decision regarding clopidogrel can be taken with the discussion, the team, post-operatively with the orthopedic team. The plan of anesthesia can be general anesthesia with invasive monitoring. Considering the duration of the peripheral nerve blocks can be taken. Again, patient is on clopidogrel, so maybe USG guided block can be considered. Patient's hemodynamic stability, avoid tachycardia and hypotension, intra plan. Blood products are prepared. Post-operative, patient will be shifted to HDU or ICU. Post-op priorities will be effective analgesia and early mobilization. Post-op LMWH with orthopedic consultation. Again, ASRA guidelines can be considered here. Resume DAPT early because he's having DES, and the cardiac monitoring for perioperative ischemia can be done. Again, the patient is old age, so polypharmacy with GA might have POCD, that is post-operative cognitive dysfunction. So delirium prevention strategy, again, help of physician or a psychiatrist. So, and who will perform the procedure intraoperatively. So if this plan of anesthesia is, ready, this clear plan is ready, then probably we can say that all domains of quality, including the timely care, including the effectiveness, efficiency, and patient-centered approach can be delivered or can be considered for this particular patients. And last but not the least, to please document your anesthesia plan. Whatever that you are doing, please document, because in the court of law, the documents should help you. It should be, speak for you, not against you. So all these plans, so we just, end up documenting that plan for this patient is GA or plan for this patient is spinal. So we can have an elaborate documentation of anesthesia plan. And to sum up, so, by considering all domains of quality and increase engagement throughout the arc of perioperative care, we become a quality champion, and there has to be some connection, always connection between. So it is always surgeon's patient, because we come as a secondary to surgical team, but it can be considered, that it is my patient. The patient has come to me for anesthesia care, so it is my patient, and we are uniquely positioned, as I said, that we are safety champions, and we are in a unique position to give that guidance and care to our patients as far as the quality is considered. So that's all from the quality domains. Thank you so much for your listening. Thank you.
Thank you, Dr. Shilpa, for your very wonderful talk. And you have covered all domains of quality care, especially in anesthesia. And you have rightly said that pre-operative planning and thorough management, intraoperative, clear instruction, clear communication with the team, delegation of the job to everyone, and timely management. And not only that, but feedback or scoring the patient satisfaction score. So everything you need to work on all domains so that the outcome of the anesthesia and surgery will be definitely very good. So with case discussion, you have nicely elaborated all domains and how we can implement them in our routine practice. And it is very, very essential, not only for the patient safety and better outcome, but for medical legal purpose also. So I think everyone is doing this, but in a structured manner, emphasizing each domain and consciously taking, if we take efforts, that will definitely reduce the mortality and morbidity. Is there any question in the chat box, Dr. Madhavi?
Yes, ma'am. Actually, we have two questions. So, Dr. Shilpa, what quality improvement projects or clinical audits can be initiated for anesthesia?
Yeah, so I think there is one topic that Deepak sir would be covering about the clinical audits, and that he will be telling you, different clinical audits. So only I'll just tell you the basic differences. The quality improvement project in any small improvement. So it goes like before and after. There is a pilot study, there is some action plan, and then there is a final study. And clinical audit, you have to just consider the standard treatment guidelines. So if there are any guidelines that you want to implement, for example, ASRA guidelines for perioperative anticoagulation. So you have to see the compliance of those particular guidelines in your daily practice and take data and how far you can improve that compliance. Suppose you are having 50% compliance, you take some action plan and then you improve the compliance of those particular guidelines. So different standard guidelines will give you the topics for the clinical audits.
Even we observe checklist.
Yes.
That is very important actually. Before starting any procedure, everyone follows that, and what is the compliance of the healthcare worker and what is the outcome. Really, we avoid the incidences of mishaps or wrong operations on wrong side. So or drug failure of drug intraoperative period or in the post-operative. Observing checklists and following the protocols will definitely improve the patient safety. Yeah.
So, ma'am, there is one more question. What mechanisms have you found efficient in capturing adverse anesthesia events?
So I think this question, can we take it after Bonagiri sir's session, ma'am?
Yeah, it's okay.
Okay.
We'll take it later.
Yeah.
Yes. Okay.
Thank you.
I think over no question. There are only two questions from.
Yes, ma'am. Only two questions.
Okay. Thank you, Shilpa. Now moving to second lecture. Actually, I have a great pleasure to invite our second international faculty from Sydney, Dr. Deepak Bongari sir. Sir's profile is very impressive. Dr. Madhvi, please share sir's CV over here. Is it possible, Madhvi?
Actually, ma'am.
Okay. Sir's profile is very impressive and he has worked extensively in the field of patient safety and quality care in healthcare. Sir is professor and intensive and clinical director of intensive care at Liverpool Hospital, Sydney, Australia. He is also the stream director for clinical care and on the board of directors of South Western Sydney Local Health District that serves the health needs of more than 1 million students, residents in Southwest Sydney. He chairs the Clinical Quality Council of South Western Sydney Local Health District and the Australia New Zealand Intensive Care Society Safety and Quality Committee. He recently set up and ran the Practical Quality Improvement course for ANZICS members and the Safety and Quality in Critical Care course for the Indian Society of Critical Care Medicine members. He has clinical academic professorial appointments at Western Sydney University, Macquarie University, University of New South Wales, and Bharati Vidyapeeth. He is an alumnus of Harvard University after having completed a master in healthcare. Quality and safety from there, he is a passionate advocate for safe, empathetic patient care and value-based medicine. Apart from that, he loves trekking, running, and recently completed the Abbott World Marathon Major in Sydney. Welcome, sir, and congratulations for your extensive work in healthcare system as well as your, various hobbies you have. Welcome.
Yeah, look, thank you for that. And look, honestly, I'll try and do only one talk. I was meant to do two, but I'm only here in Pune for 2 days, and I want to spend some time with my family. So I'll only talk to you about clinical audits and anesthesia and talk about how to move from practice to improvement. So I was going to talk to you about a case study of a cardiac arrest after spinal anesthetic. But this case study then led to us looking at blood pressure drops after spinal anesthesia for cesarean sections. So this is an example of an audit that we did. So the background is you all prefer to do spinal anesthetics for elective cesarean section, with hypotension being the most common complication. And that can lead to maternal and fetal complications, as you all know. So an audit question that you can draw around this and that you can conduct an audit is, what is the median drop in the mean arterial pressure following spinal anesthesia for elective cesarean section in our institution, and how does it compare with the best practice guidelines? So any one of you in your hospital can do this, and a standard or a guideline that you can use is MAP should not fall by more than 20% for its baseline or less than 70 millimeters of mercury. This is a common standard. It makes good sense, and it's something that you should try and defend, and the treatment should be initiated appropriately. So then what do you do with the audit? So you use an audit methodology. You collect data, prospectively audit over 3 months. You look probably at 100 consecutive Caesar sections, exclude emergency cases, failed spinals or combined techniques. Look at variables like the baseline, the lowest MAP, and the time to hypotension, and the interventions that were done. So this will be the data you collect. Your baseline MAP is recorded preoperatively every 2 minutes for the first 15 minutes post-spinal, and then every 5 minutes. So this is how you set it out. This is not something I'm recommending, but if you're going to do an audit, this is what you should do. You should say, this is what our study will look at. And what are our primary outcomes? We said median percentage of MAP from baseline. So this is the audit. And then you record the intervention, how much fluid you need to give, how much vasopressors, and time from the spinal to the intervention. So this is the results of the audit that we did. The median drop was 28% with an interquartile range of 22 to 35%, and 73% have that drop. 42% of patients have this drop. So this is the audit that we did. The mean time was 4.5 minutes and 85% required vasopressors. And the standard map did not exceed more than 20%. So we used metaraminol. I know you use mephenteramine here or ephedrine, and we use fluids for the bolus. So the gap analysis. So what you do after you got your audit, you identify the issues. And the issues showed that 73% of patients exceeded the threshold. There was inconsistent fluid preloading protocol, delayed recognition and treatment of hypotension, variable vasopressor dosing, and no prophylactic vasopressor infusion protocol. So people are not starting vasopressor infusions or don't have vasopressor ready. So what's the action plan from this? You develop a standardized protocol. You can load with 500 mils of fluid or give prophylactic metaraminol or whatever vasopressors, and you can say we'll implement that in a month. You educate your staff to hypotension risk. You use monitoring tools, so you set up a standard for the monitoring and then documentation of the blood pressure. So this is how you kind of act upon your audit. So the classification of anesthesia audits, the ones that we can do and the ones that we do, can be clinical audits and non-clinical audits. So in clinical audits, you have patient safety and care quality. So that's in your preoperative assessment, your intraoperative, and your postoperative care. So you can audit all these things if you like. And you can do non-clinical audit, as Shilpa said, you can look at resource management, you can look at operational efficacy or efficiency, documentation audits, and safe system audits. So that's roughly how you classify your audits. The preoperative audits, the good ones that you can do is look at a documented assessment within 24 hours, and the measure that you use is the percentage of patients with a complete assessment and documentation of ASA classification, and the key outcome is a completeness score. Or you can look at high-risk patient identification and what you're doing with those patients as an audit. Or you can look at informed consent audits. So intraoperative audits, the ones that you can look at are the safe surgery checklist compliance, and you really need to have 100% compliance. Monitoring standards, whether you've got ECG, non-invasive blood pressure, capnometry, and so on and so forth, if that's available, that would be another intraoperative audit. Critical event documentation, and that's really important that you do that, and you look at so you can audit that. And antibiotic prophylaxis, when are you giving it? Are you giving it within 5 minutes of skin incision, before, after, and what the guideline is from your infection control and infectious diseases. So these are other intraoperative clinical audits: airway management complication, the rates of first pass intubation, regional anesthesia success rate, blood product use appropriateness, and medication errors. So lots of audits that you can do. And postoperative clinical audits that you can do is look at postoperative nausea, vomiting, pain management, recovery, discharge criteria, how many patients go to ICU or HDU, and postoperative complications. So really, you can look across the entire spectrum of a good anesthetic service and audit it. And these audits don't need to be conducted concurrently. You can take up 2 or 3 things that you're going to audit every year. What we do is all our trainees need to do an audit when they are with us. So if you've got 5 or 6 trainees, you can do 5 or 6 audits every year and get them to present the audit at an end of year quality assurance meeting. And that's a good way of making sure that audits are completed. And secondly, that you're training the next generation of anesthetists. The clinical audit cycle is a continuous improvement cycle where you identify a topic, you set a standard, you collect the data, you analyze the result, you implement the change, and you re-audit. So it's not something that you stop, it's a continuous improvement cycle. Data collection can be prospective, so you can collect real-time data, tends to be more accurate, but it's time intensive. And for an example is observing 50 consecutive spinal anesthetics. It can be retrospective where you can review existing records. It's quick, cost effective, and you can get a large sample size. But it depends on your documentation and there'll be missing data. An example is 200 anesthetic records from the last 6 months. Or you can do a mix of prospective and retrospective things, which balances accuracy with efficiency, but the methodology is more complex. An example is prospective for key events and retrospective for demographics. So you can look at the incidence, for example, of hypotension prospectively after a spinal anesthetic, but the demographic of the patient, you can look at it retrospectively to see which patients are there that tend to have more of hypotension. The sample size for descriptive audits generally have about 100 minimum. For rare events, we think 30 events captured is good. For example, if you're going to do an audit of malignant hyperthermia, you probably see one case every 5 years. So you'll have to go back a long period in time, or you'll have to have a lot of centers. So for rare events, a small sample size is enough. For quality improvement, before and after, at least 30 each is what we recommend. And consider PAR calculation if you're going to do critical and large audits and account for missing data. You always will miss about 10% of your data. And you can look at your data as descriptive, mean, median, standard deviation, and percentages. Compared to a standard, that's called gap analysis, stratify by ASA and so on, identify patterns and trends, statistical significance versus clinical significance. So one of the things as clinicians you should always be important look at is statistical significance may be achieved, but it may not be clinically significant. So for example, a 5 millimeter mercury drop in blood pressure may end up being statistically significant, but we all know that it's not clinically significant in most patients. The pitfalls to avoid are having a very small sample size, a bias in your selection. So if your selection is non-representative, your data collection is inadequate, you only look for things that you expect. So if you're going to look and say, oh, I expect the blood pressure to drop with spinal anesthetics by this much, there's already a bias that you've introduced there and no action plan. So if you do an audit and do nothing about it, that's no good. So do an audit, learn from it, and change what you're going to do. So types of data, and most of you will be aware of this, it's categorical or continuous. Categorical data is qualitative and describe characteristic, whereas continuous data measures something. So gender, ASA class, etc. Categorical, and discrete data, number of intubation attempts, APGAR score. Ordinal has an order, so pain score is an ordinal score, sedation level is an ordinal score, and continuous data like blood pressure, body weight, and so on. So descriptive statistics for categorical data, you can look at frequency, proportions, mode. For continuous data, you can look at mean, median, and standard deviation. And that continuous data is what is often reported in clinical trials when you do large-scale clinical trials. When you do smaller audits, look more at categorical data for frequency or proportions, because that's going to give you the data that you want. If that data looks really big and exciting, then you can convert your small clinical audit into a large, well-funded, adequately powered clinical trial. When to use means and medians? Use mean when the data is normally distributed, so that it's in the bell curve. Whereas if you have a bimodal or a trimodal distribution of data, use the median. What we do is when we design a study or an audit, we often have statisticians from universities talk to us and tell us what is the best way to collect our data, or somebody with more statistics information. Visual presentation of audit data is very important because most of us are visual learners. So you want to represent your data properly as a bar graph. So bar graphs are very easy to look at, or a pie chart, which gives you a percentage, or a histogram, or a scatter plot. So statistical tests in anesthesia audits. So if you're doing categorical, there are two groups. The test that you'll use is a chi-square or a Fisher exact test, and that is used in post-op nausea, rate, GA versus final, and so on. So these are all the tests you can use. You can use, if there's normal data, you can use analysis of variance or an independent t-test. For continuous non-normal data, you can use Mann-Whitney or Crookes Crocus-Wallace test, and a paired t-test are used mainly for before and after. Mainly what my advice to you is, if you're not doing this all day, every day, and you're really going to embark on a big study, have a statistician as part of a team. Do not do studies without having a proper team. So you be the big clinician, you have somebody who's got experience in clinical trial design, and a statistician, and a good team of data collectors, and more importantly, have money and have funding and have the support of your seniors in the hospital or in your department. We all know what we always use a p less than 0.05 in medical statistics to reject or accept the null hypotheses. So practical completed audit looks like this. We saw 120 patients pain management after laparoscopic surgery, and we divided them into standard and enhanced anesthesia protocols. So the data there was categorical, ASA class, post-op nausea, vomiting, continuous data was age, BMI, and so on. The descriptive statistics was the mean and median pain score with interquartile ages and the percentage of patients with pain more than 4/10. And what we found was in the standard group, 75% of patients had pain score greater than 4, and the enhanced protocol had a pain score, only 35% had it. And then we used the statistical test, which is an independent t-test and a chi-square test, to compare the percentage with pain, and we found that the p-value is less than 0.01, and so you have a significant difference. So then you can conclude that the enhanced analgesia protocol significantly reduces pain scores with a mean difference of 1.8 and reduce the proportion of patients with moderate to severe pain from 75 to 35%, which is statistically and clinically significant. So the end of this audit will tell you that you performed a really good study and that your enhanced pain protocol should be implemented more widely. So presenting the audit results, always have an executive summary and introduction, what methodology you use, what results you got, and what your discussion and recommendation and re-audit plans are. So the best practice for successful audits are choose topics that are relevant and which you can do, use clear standards, have multidisciplinary engagement. So engage your surgeons, your nurses, and your pain specialists. Keep the data collection as simple. Feedback to everyone who was involved in it. So 2 or 3 of the anesthetists have contributed patients to this. Tell them, look, the study went well and here's what it is, or discuss it in your meeting. Make smart recommendations, specific, measurable, achievable, relevant, and time bound. Close the loop. Re-audit if required, and use audit for continuous professional development. So if you've done an audit, make sure your society knows about it and you get the CPD credit for it. So the key takeaways of my talk are that clinical audit is important for quality improvement, focus on patient safety and measurable outcomes, identify, measure, analyze, improve, re-audit, and implement the recommendations. So don't just audit, make some recommendations and implement them. I'll take a couple of questions if that's needed, but I'm really sorry. I just do honestly have to spend a little time with my family when I'm here. So I might stop there.
Yes, thank you, sir. Thank you. Thank you for your very informative, illustrative talk on audit in anesthesia. And you have rightly mentioned that audit of each and every event is essential to take a measure or action against it. And audit is a clinical audit it is a continuous improvement cycle, and it is very, very essential to do by everyone for the better outcome from the anesthesia. You have explained very nicely, and thank you. Thank you very much for giving your time and coming over here, sir.
Thank you
Just-
so much, and wish you the best for the rest of this session. Thank
Yes,
you.
sir. Thank you. Thank you very much.
Can we just have a small question, sir?
Yes, of course.
Yeah.
How can we ensure a sustained improvement in our clinical audits?
So the way I would look at it is, if you do your audit finds you recommend something, you re-audit. Once you find that there is an issue when you re-audit, that you're not getting the sustainability, then you convert your audit finding into a key performance indicator. So, for example, if you're seeing that let's say, in your cesarean sections, the incidence of hypotension to less than 70 on repeated audits is, let's say, 20%, and you find that's unacceptable. You say to your team and your staff, we think that this is unacceptable, and we are going to regularly audit. And our KPI for the department is we should have 0 patients with a blood pressure less than 70 during an audit. That is your key performance indicator. And then if your anesthetists or your teams are not achieving it, then you make it an adverse event that is reported. You analyze that report and you find whether there are patient factors, there are anesthetist factors, drug factors, or system factors. And you start fixing those factors, go back and audit and make sure that people understand. So the only way to do it is to re-audit and use your audits, especially for the big things, the things that will kill your patients, the things that will affect their quality and life and so on, is to have strong indicators and to say, we do not accept this. And if it happens, we will investigate it and we'll see if it needs a system to be changed, or we'll see if it needs individuals to be held responsible. So the moment you do that, you will find that people change their behavior, change their habits, and also the system will change and you won't have these events.
Yeah.
I hope that answers your question.
Yeah.
All right.
Surely,
Well,
sir.
thank you.
Yeah. Okay.
Thank you very much for the invitation, and I wish you all success.
Yes, thank you, sir. Thank you very much, and wish you happy journey. Yeah. Because of time constraint and sir is having some other commitments, he is not able to talk on serious adverse events reporting investigations. But instead of that, now I would like to invite Dr. Shilpa madam again to introduce give introduction about the adverse clinical events in anesthesia. Over to Dr. Shilpa madam. Sir has nicely, very well mentioned. I think Dr. Shilpa is sharing her slides. I would like to comment on the previous talk that CAPA, we say it as a CAPA, that is corrective and preventive measures are very essential after each adverse event. So audit and later on CAPA is essential for the better outcome and to implement the recommendations on it. So every event must be, CAPA must be done for every adverse event in perioperative period. So as to that, we cannot make same mistake of same error in subsequent patient management. Yes, Dr. Shilpa.
I'll be just briefing, because the serious adverse event analysis, it's investigation, it's a very vast topic. So I think the time won't permit for that. So I'll just introduction on the definitions of the serious adverse event, maybe I'll cover in this session. So as everybody knows that the event, as incident reporting. So anything which is unexpected, which we are not expecting. It could be patient fall, it could be extravasation, it could be some complication intraoperatively, so something which is unexpected that is happening in the operating room in the perioperative period, and we can definitely report it as an incident. Now WHO has given some category of how the adverse events can be categorized as. So it classifies the term incident as uncompleted errors, that is, they can be called as near miss. Now by the term near miss, we, as is defined as there is something which is error has occurred, but error is prevented to reach up to the patient. For example, a nurse is directed. Suppose I tell my nurse, the anesthesia nurse, to give injection midazolam 1 milligram, okay, and 1 ml, and the scoline and midazolam ampules or the vials are placed side by side, and she aspirates injection scoline, okay, 1 ml, and I see to it that in time that there is some error that has occurred, and I immediately tell the sister or the technician that please stop. This is scolding. So there is some error that has occurred, but it has not reached the patient. So there is no patient harm that has even occurred. And in healthcare, we see to it that maximum near misses are reported to quality. And if the near misses are maximum, that means the vigilance that your system is having is good. And we also have a system that we have a token of appreciation for every person who identifies a near miss event. So maximum near misses will see to it that your system is good. Yeah. And if you consider the harm category, incidents with no harm, and then mild, moderate, and serious harm. And then certain incidences which are reported as sentinel event also I will be covering. So any serious adverse event is an unexpected occurrence which is involving physical or psychological injury, and therefore of including a life or the function of the system. And the NABH 6 guidelines have also given a definition of adverse event, that is injury which is related to the medical management, which is leading to complications, which is not related to the complication of the disease, and it may be preventable or non-preventable. So that preventability factor is also considered into the definition. Adverse events, by definition, has been given by different, like there is a Ministry of Czech Republic, there is some US FDA guidelines, but by far, foremost, the guidelines that we are considering is the NABH guidelines, and it can be also defined as an anticipated event or occurrence which is involving death or serious injury or physical or psychological injury, which is not related to the patient's illness, but it is related to some system issues. It could be equipment related, it could be supplies related, or care related injury. The Joint Commission International also defines the sentinel event as the patient safety event which is resulting into death, permanent harm, or severe temporary harm. Right. National Quality Forum, which is an affiliate of Joint Commission, also defines the serious adverse event as an preventable serious harm that should never occur. So they are also termed as never events in the literature. So, this concept of sentinel events from 2013 also includes the serious adverse events or the serious harm which is occurring to our patients, but also to our staff. Okay. And therefore, they are the serious adverse event related to the staff, any healthcare, a faculty or any paramedic staff is also included in the serious adverse event definition. And they are both important to our patients as well as to the faculty, because any such particular event, even a single event which is occurring, will be a lifetime experience for that particular healthcare provider. And we should not forget, I want to mention here the second victim syndrome, because the patient which is involved in the serious adverse event receives a harm, but the staff or the healthcare provider who is also involved is also receiving some harm. There is some psychological harm, and that person is called as second victim. And there is a second victim syndrome, which is a term that is scientifically used now. And every second victim in the healthcare should be given a support. So that second victim syndrome is, we should have a policy of second victim syndrome in every hospital, and how to implement the support to second victim should also always be discussed. So sentinel event by far should fulfill these 4 criteria. It should be unrelated to the patient's natural course of the disease. They should be unexpected or unanticipated, and some system issue should be identified. And last, serious nature of the event should be considered. Now, few of the sentinel events are not serious. For example, incision on the wrong limb. It is a sentinel event, but may not be serious in the nature, but they also should be included in the sentinel event. So, this is a list of some sentinel events that are occurring in the surgical patient. For example, wrong site, per surgery, wrong patient. Sometimes same name patients come to our hospital. They are admitted and they are posted for some surgery, one after the other. So always identify patients with the 2 identifiers. So wrong patient surgery again is a sentinel event. Wrong surgical procedure, retention of a foreign object, hemolytic blood transfusion reaction, medication error, which is leading to serious harm. Some mechanical or physical restraint related injury requiring, resulting in the serious harm or death of the patient. Incorrectly position nasogastric tube, leading to aspiration. So all these are a list of sentinel events. And in the literature, the main serious adverse events related to anesthesia could be respiratory, drug related errors, and cardiac and neurological error. And the commonest is the difficult airway, followed by some massive hemorrhage perioperatively, hypotension, bradycardia, re-intubation that are occurring. And if you have a policy in your department that all serious adverse events related to anesthesia or perioperative events, if you have a policy of reporting and analyzing, it will definitely fetch you, and it will improve your quality care in anesthesia. Yeah. So, this British Journal of Anesthesia, of an article which is published in 2022. So it gives, some serious adverse events that are occurring in anesthesia. And primarily, there are 3 components of any serious adverse event. First is the causation component. Then what is the actual cause, the root cause analysis. Then what is the outcome? How far it has gone harming the patient, and what is the preventability. Now, if you consider WHO, draft of serious adverse events, so, many serious adverse events that are occurring they reflect the system-related issues, and sometimes they are not caused by an error. So you have to really dig deeper into whether it is related to some system-related issue, or it is occurring as a perioperative complication or a clinical incident. Again, the preventability or avoidability component you can grade as per this article in the Korean journal. You can have a category like 1 to 3, they are avoidable, 4 to 6 are possibly avoidable, 7 to 9 are, maybe they are unavoidable. So you can definitely have a grading system of preventability or avoidability for every anesthesia related incident. So, incident of critical serious adverse event is around 9 per 1,000 anesthetic procedures, and most prevalence of cardiac arrest is again, it again varies per 1,000 anesthetic, right from, around few percentage to as high as up to 3 to 4%. And, JCI also has been reported many serious adverse events that are related to anesthesia. Again, the frequency of medication error occurring in anesthesia practice is high as 5%, and the serious adverse event in the clinical incident in anesthesia is up to, in UK statistics, is up to 10% of the hospital admissions. And as I said, it is this the iceberg phenomenon. So many of the adverse events are not reported. Now, JCI also doesn't make it, mandatory reporting. Even in India, it is not a mandatory reporting. So the reporting in serious adverse event is voluntary, and we should come up with the non-blame approach, analysis of the serious adverse event, and then only the reporting will increase. So this is the only study which is done in the Indian perspective where the critical incident reporting in anesthesia is concerned. And again, it says that the human error was the most common responsible factor. And whenever there is human error, we should have some interfacing between human and the error. The interface can be a technology, interface can be double verification, interface can be privileging of the staff. So if you have something between error and the human factor, then the serious adverse event that are occurring will be reduced. Again, last year's report by World Federation Society of Anesthesiologists. So critical incident analysis should be promoted, and it leads to quality improvement. It leads to risk reduction strategies that can be implemented, and it improves the standard of care. It reduces the fear of litigation, and it reduces overall medical cost. And therefore, this is just the introductory session of the serious adverse event. And at present, there is National Patient Safety Framework given by Government of India, which says that the incidents, serious adverse event reporting will become mandatory in India in future years. So maybe in a few years, we will, we can expect that all serious adverse reporting will become mandatory. And the Government of India is also planning to have a national, some portal in which all adverse events can be mapped, and some systemic related policies or some measures can be introduced by government so that the anesthesia care can be improved. So that's all about the serious adverse event. Thank you so much.
Thank you, Dr. Shilpa, for your wonderful talk. Though it is a just introduction to sentinel or adverse events in perioperative period, and we all now know that anesthesia is such a high risk, medical branch in which we face, even though we are very particular and meticulous, there is always a risk of happening the adverse events, and for that we need to take all essential steps right from beginning, pre-operative to post-operative. And reporting, as you said, the unreporting or underreporting is very, very common, or is the picture in India. And that's why, though the incidence of mortality and morbidity is high, because of non-reporting and proper audit on that, actually further steps or actions or recommendations are not being taken. And under the means non-reported incidences are there, but everybody must take precautions and must report. And as you said, non-blame manner, we should report the incidents and must take the proper action on it. Thank you, Dr. Shilpa. Thank you very much. Now we will move on to next. Sorry, is there any question?
Yeah, we have 2-3 questions.
Yes,
So, somebody want to know, will needle stick injuries to staff count as sentinel event?
Yeah.
Needle stick injury.
It is not a sentinel event per se, but definitely it is an incident.
So it has to be reported.
And it has to be reported. And depending upon what is the status of the patient from which the NSI has occurred. So if the patient is seropositive, what is the viral load of that patient? Because seroconversion after NSI is high if the viral load is high. So that can be considered. And you should have a standard protocol, from the infection prevention control, that every NSI, how you are, even the patient is negative at that time, the patient can be in the window period. So all negative NSI should also be followed for a period of time so that window period is over, but definitely reported. NSI should all be reported, but not as a sentinel event. And again, if you want to have a sentinel event, NSI as a sentinel event, it can be an organizational policy. So
Yes.
if you're in your organization, if you are having high NSI, so you can, if you want to improve, so it can also be included in the sentinel event. So again, it depends on the organization to organization.
Okay. So protocol has to be set up for that particular.
Yeah, and healthcare education, we can give proper healthcare education means to the healthcare workers how to protect the needle stick injury, because many times because of lack of knowledge and because of not following the proper instructions or protocols, such events occurs in the hospital.
Yes.
Yeah.
So one more question. Reporting of adverse events is minimal. So how can we encourage that? Any measures we can take for that?
Yeah. So reporting, first of all, the stakeholders, the faculty and the staff should understand that the reporting will not come as them as their error or their mistake. So we have to always formulate a investigation committee, and the committee should ensure that the reporting investigation will not come to as pinpointing that this faculty has erred, that mistake has occurred by this so and so person. So we have to have a blame-free approach for incident reporting. And in quality, it is always top-down approach. So unless management is keen, serious adverse reporting, the management has to be very keen, and then only it will trickle down to the bottom. So first of all, the management should ensure that it will not be a punishable thing. So non-punitive and blame-free approach will definitely have thing. And maybe in the initial phases, when you're starting the reporting, you can have a closed door meeting. So it has to be kept confidential, and you have to ensure to your staff that everything that has been investigated will be kept confidential.
This will promote, I think, the reporting more.
Yes, ma'am. Yes, ma'am.
Yeah. And can we take the previous question, like what mechanisms have you found efficient in capturing the adverse anesthesia events?
So mechanism in the sense, is that pertaining to the data collection or? So maybe if it is the data collection, then you might like we are having one Google form that we have prepared for our institute, and every serious adverse event will be reported. Or you can have some register that is kept in the operation theater, so that all serious adverse event, and we analyze it. Monthly analysis of all serious adverse event is done, and if we think that some system related factor is involved, so there is a committee which sits, and all serious adverse event are seen. If there is a factor of preventability, then definitely the reporting will occur. Not every anesthesia event you should report. There will be some complication. Those complications will be, known complication as far as the surgery is concerned. So there should be data which, all anesthesia and perioperative events you are jotting down, you are taking data, but not all incidents should be reported as an incident. So the incident will be reported of those events which have some system related issues.
Okay. And one more question. Giving regional block to wrong side, is it just an incident, or we should label it as a sentinel
event? It is a sentinel event.
Yeah.
Definitely.
Yeah.
Yes.
Thank you, Dr. Shilpa.
Yeah. Okay. Thank you. Now we will move on to our third lecture. I would like to invite our third speaker, Dr. P. Parshuraman. Sir is there, no? Yeah.
Yeah, I'm here only.
Yes. Sir has done MBBS and diploma in anesthesia and DNB. He is head of the department anesthesia at Clinical Hospital, Kengari, Bangalore. And he had held many positions before the present one. He was head of anesthesia department, Apollo Hospital, Kakinada, Andhra Pradesh. He was in charge anesthesia department of Sagar Hospital, BSK, Bangalore. And he has additional qualification. He has done national PGD, ML in National Law College. I think that is a law degree from Bangalore. He has also done MBA in hospital administration from Acharya University, and also LLB, Karnataka State Law University. So welcome, sir. And sir is going to talk on quality indicators in anesthesia. Over to you, sir.
Thank you, ma'am. Thank you for the introduction. And I thank and I appreciate Dr. Shilpa, Dr. Madhavi, Dr. Shalini, and Dr. Deepak for your support and coordination for this webinar. Now my topic is quality indicators in anesthesia.
Yes, sir.
Just a minute. Next one. So after the Dr. Shilpa has explained about what is the quality and what are the components of quality, and Dr. Deepak has explained about the audit. Before knowing about the quality and the audit, there is something called quality indicator. So we have to know about what is a quality indicator. Without quality indicator, we cannot have a completeness of the quality system. So what is a quality indicator? Quality indicators are the object which is a measurable and which is a evidence-based tools used to assess, monitor, and improve the quality of process, service, and outcome. For example, if there is a quality indicator that we are going to monitor, say like hypertension, that hypertension is an objective and that is a measurable and that is a evidence-based. Hypertension is happened due to what? And that gives the quality of process, service, and outcome. Why the hypertension has happened, what are the reasons, and what is the outcome to the patient. That is the meaning of a quality indicator. Why are they important? The pioneers in quality has described that what is not measured is not managed. If something is not measured, it is not managed. In simple, to say that if something is not monitored, it is not evident. If something is not taken for auditing, that is not reflective in the outcome. So indicators are instruments that synthesize a set of information into a single value. Therefore, they allow certain phenomena to be measured among themselves, also known as key performance indicators. So the quality indicators in general can be called as a key performance indicators. Indicators are essential for quality system. The quality in general describes the outcome, process, and structure. So how quality indicators are formed? Quality indicators are formed generally in terms of two methods. One is the original Delphi method that is formed in the 1962. That original Delphi method is nothing but a collection of panel of selected experts and an open questionnaire is put to them and a specific information is gathered from them and that specific information is taken as a quality indicator. Later came the modified Delphi method. Instead of putting an open questionnaire to the panel experts, literature-based question is put to the team of members and the pre-selected set of items identified by literature search rather than an open questionnaire. What are the characteristics of a quality indicator? The term quality indicator, which also means a measure or a metric, and these three terms are used inconsistently and interchangeably. A quality indicator should measure something important in a scientifically sound and should be practical. It should have a potential for the future improvements. Indicators should results should be reliable and valid. Indicators should be feasible and applicable for potential audience. Indicators should be used for research purpose. What are the examples of quality indicators used in research purpose? The common thing that is used in a research purpose is a study called compact step. The compact stands for core outcome measure for perioperative and anesthetic care and standardized endpoints. The step is the standardized endpoints. Compact seeks on what to measure and step on how to measure. Examples of compact step outcomes like postoperative mortality and morbidity, length of hospital stay, unplanned readmissions, patient-controlled outcomes, 30 days of surgery death, infection at 30 days, admissions to ICU, cardiovascular outcomes, infection and sepsis. pulmonary complications, post-op cancer outcomes, renal endpoints, and patient-centered outcomes. And instead of giving a generalized quality indicators, there are specific quality indicators also, like perioperative patient safety, regional anesthesia, perioperative pain management, obstetric anesthesia, cardiovascular assessment outcomes, failure to rescue. This is the most important quality indicator that has come into focus now. Is increasingly supported as a quality indicator because it reflects the ability of hospitals to treat complications early and prevent death. Examples of quality indicators developed in clinical practice. Various society of anesthesiologists have their own set of quality indicators. Anesthesiology societies like German Society of Anesthesia, Swiss, Austrian, Danish, Royal College of Anesthesia, American Society of Anesthesiology, World Federation Society of Anesthesiologists have their own set of quality indicators. What are the challenges in establishing quality indicators? When the quality indicators are not defined properly, it is difficult to measure. And there is variations in recording the data. Practical obstacles in funding, necessary structures, technical requirements, and employee compliance, inadequate register maintenance. Inadequate register maintenance means recording the patient details that is different from the anesthesia and different from the surgical side, and it is different from the central registers. What are the opportunities for establishing quality indicators? Professional societies can support research and practice development aimed at advancing indicator contents. Professional societies may contribute to increase the utilization of existing data for quality purposes. Cooperation between government and professional societies or other organizations should contribute to realize the link between registries. Implementation of continuous professional development and continuing quality improvement. What do you mean by continuing professional development? Continuing professional development refers to the ongoing process of developing new knowledge, skill, and competencies necessary to maintain and improve professional practice. Continuing quality improvement is a systematic approach to assessing and improving quality of care by professionals, which involves collecting data on indicators of quality and using the data to identify areas of improvement and develop strategies to address them. Anesthesia quality indicators. Anesthesia quality indicators are specific measures used to assess clinical area in anesthesia. Heller et al. Published a systematic review of quality indicators in anesthesia in 2009. An important distinction between Heller et al. Study and compact step study is clear definition of outcomes rather than physician performance improvement. Anesthesia quality indicators list is relevant and should be available as like anesthesia information management systems. The Canadian Society of Anesthesiology has a list of anesthesia quality indicators like airway complications, that is greater than 3 attempts at intubation, cannot intubate, cannot ventilation, laryngospasms, hypoxia, dental and soft tissue injuries, incidence and duration of perioperative adverse events, degree and duration of hypertension or induction, that is systemic blood pressure less than 80, number of medical errors, medication error with wrong medications or wrong dose given, number of wrong site or side procedures, patient satisfaction, postoperative residual neuromuscular blockade, temperature less than 35.5 Celsius, complications of neuroaxial blockade, that is failed block, inadvertent dural puncture, eye block, infection, neurological complications. Inadequate regional or neuroaxial block requiring supplemental analgesia, sedation or conversion of GA required for surgery. Epidural or neuroaxial technique not working as planned, inadequate pain coverage, necessitating additional interventions. Incidence of severe postoperative nausea and vomiting, that is 2 or more episodes of severe nausea or vomiting over 6 hours apart or requiring more than 2 doses of antiemetics. Patients who receive an intervention by anesthesiologist for PONV not responding to PACU protocols in the recovery period. Complications of central venous line placements, intervention required by anesthesiologist in PSU to relieve respiratory distress, perioperative cardiac complications, adequacy of postoperative pain management, all-cause complications within 30 days or until hospital discharge or death, proportions of patients receiving appropriate surgical antibiotic prophylaxis, unplanned overnight admissions of day surgery patients for anesthetic reasons, pain scores on arrival to PICU, cerebrovascular accidents developing during or within 48 hours of anesthetic care, monitoring hand hygiene, adequate perioperative management, incidence of intraoperative awarenesses, incidence of delirium during the postoperative period, patient requiring on intervention by anesthesiologist for circulatory or hemodynamic reasons in the recovery period, critical incident reviews for rare and infrequently occurring events, ultrasound used for vascular access procedures, unplanned admissions to ICU or HDU within 24 hours of procedure. So the list is big. It covers the 56 indicators that is developed by Canadian Society of Anesthesiologists, which involves in each area of our performances. So apart from these 56 clinic quality indicators, there are common 10 anesthesia key performance indicators to track. Number one is intraoperative hypertension exposure. When the mean arterial pressure drops below 65, when that is for more than 5 to 10 minutes, is one of the strongest anesthesia quality indicator to monitor. Next is the normothermia, that is or post-anesthesia hypothermia rate. Maintaining normothermia is important with a core temperature above 35.5 degrees Celsius upon arrival at the PICU or within 50 minutes post-anesthesia is vital for reducing wound infection, bleeding, and prolonged recovery. As I discussed previously, postoperative nausea and vomiting rate. Leading centers aim for incidence of less than 10 to 20% in high-risk patients, adjusting for procedure type and patient profile. Airway complications rate, difficult intubation, airway trauma, unplanned reintubation, or rescue devices use is essential for patient safety and team performance. Residual neuromuscular blockade incidence. Measuring the percentage of patients with a train of 4 ratio below 0.9 on PSU arrival or those requiring additional reversal gives a clear picture of quality. Unplanned ICU admissions within 24 hours. First on time starts and OR turnover time. That is the utilization of OTs. Multimodal analgesia utilization and opioid per cases. Patient satisfaction with anesthesia care. As Dr. Shilpa was explaining previously, patient reported outcome measures and patient reported experienced measures. Documentation and completeness and data capture timelines. This is the most important quality indicator where when all the incidences and monitoring is documented, from the document we can collect what are the data that is important to monitor the patient and what are the errors that has happened during monitoring and during performance of anesthesia. Why are anesthesia quality matrices crucial right now? That is failure to rescue. When a major or sentinel events happen, when you are not able to rescue the patient, why the failure has happened? When you apply all these quality indicators, then we get a clear picture that where we failed and what are the steps where we can improve, what are the errors that can be covered. Anesthesia quality key performance indicators are the foundation for safer patients, stronger teams, and smarter data-driven anesthesia care. How do anesthesia quality metrics improve patient care and performances? In 2025, hospitals that consistently track and act on anesthesia quality metrics and anesthesia quality indicators will lead in patient safety, efficiency, and satisfaction. Choosing the right KPIs, the key performance indicators that we have to choose based on type of the cases we do, based on the seniority of anesthesiologist involved, based on the infrastructure that is in the hospital, So choosing a right KPI is the most important in assessing the quality indicators. Integrating them into everyday workflows and using analytics platforms to turn data into insights create measurable improvements in anesthesia care. Each indicator, from blood pressure stability to documentation accuracy, helps team understand performances, strengthen outcomes, and demonstrate value across perioperative services. So, these quality indicators, what it is going to give is that it gives the demonstrated value across perioperative services. So once a quality indicator is defined, we know what is our efficiency of the services, we know what is our weakness, we know what is our errors, we know what are the areas to be improved, and this sets a benchmark to improve our quality services and to create the guidelines and to create the care pathways. With this, I finish my presentation. Thank you.
Ma'am, you please unmute. You are on mute.
Yeah.
Any doubts?
So I'll just check for the questions.
Questions? Video close. Video close. Good.
गुड इव्हनिंग सर. साळे सर दिसले आता मला.
अरे मी पहिल्यापासून आहे.
ओके ओके ओके. थँक्यू. Is there any question, Madhavi? Sir,
Good evening, sir.
Sir want to say something, I think. Sare sir.
Hearty congratulations, Dr. Shilpa. It's a wonderful and excellent
Thank you, sir.
this thing. Whatever you spoke from the first line, a brief history followed by the way in which the subject went ahead. And even Dr. Deepak and Dr. Parmeshwaran, what they have brought to today's topic in anesthesia particularly. These two, all the subjects are important, the clinical subject, but two subjects are very, very important in the quality. That is, one is anesthesia and another is the radiology, where the safety, particularly in anesthesia, very narrow margin of safety is there. So Dr. Parmeshwaran took lot of quality indicators and KPIs, and Shilpa has explained thoroughly about the topics. Congratulations.
Thank you, sir.
And I had forgotten actually today, but your message I saw today something Shalini has sent a personal message means. Then I just saw and I immediately told her I'll join.
Yeah.
मी 7 वाजता join झालो.
Yes. Thank you, sir. Thank you very much.
Just a question for Parshu, sir. Sir,
Yeah,
which is the most commonly used quality indicator in anesthesia?
The most common quality indicators what we use in our hospital or from the point of NABH is the adverse anesthesia reactions.
Okay. Okay.
Is there any other question? Anyone want to ask anything? I think we have covered almost all topics. So I would like to give concluding remarks over the topic. As our speakers mentioned that perioperative complications are very common either because of poor care of patient, lack of knowledge, poor skill, lack of assessment of our own skills. Errors are contributory factors. The safety culture in the perioperative setting addresses critical components important to healthcare, including patient safety, staff support, and the identification of system issues. These concepts are important to healthcare in general and critical in the high-risk perioperative environment. Hence, an approach that emphasizes understanding, integration, engagement, and accountability for safety by each team member for every patient, every time, every day need to be implemented. Thank you. Thank you, speakers, for your wonderful contribution and enlightening us on the various aspects. And it was a great activity. Thank you. Thank you very much. Now,
Thank
I would
you.
like to invite Dr. Vandana Nande Madam to give vote of thanks.
Thank you.
Good evening.
Yeah.
Good evening, all. On behalf of Society of Anesthesiologists Pune, I sincerely thank President Dr. Avinash Bhosle sir, Vice President Dr. Karne sir, Secretary Dr. Sheetal Dalal ma'am, and President-elect Dr. Rajesh Tagadpalle sir, and the entire team of SAMS for providing us an excellent platform to conduct the webinar. We truly appreciate your constant support and encouragement. I am deeply grateful to all our esteemed faculty for accepting our invitation and delivering such insightful lectures on quality care in anesthesia practice. The sessions have entirely enriched us, and I'm confident that everyone will enhance their patient safety skills and further strengthen the anesthesia practice. I also extend my heartfelt thanks to all the delegates for their active participation, which made this event a success. Special thanks to Mr. Ganesh and the entire technical team for their seamless support and service. Thank you once again. Jai Hind, long live SAP, long live SAMS, and long live ISA.